Okay, hello everyone. It's a big pleasure to participate in this diabetic neuropathic food and its consequence course, and I thank for the invitation from the organizers. The topic that I'm going to talk with you is about the prevalence, incidence, and the main studies of epidemiology and the factors that give influence in prevalence data. I am Hermelinda Pedrosa. I am an endocrinologist from Brasília, Brazil. Among of these activities, I am presently the vice president of the International Diabetes Federation, but also I am the chair of the research center at the unit of endocrinology of the Secretariat of Health here in the capital of Brazil. I don't have any disclaimers for this presentation. And I will start saying that diabetic neuropathy refers to a broad spectrum of different conditions. And when we say diabetic peripheral neuropathy, we refer to the most common and most studied presentation of this very complicated disease of the diabetes. So when we say DPN or diabetic neuropathy, we have to consider the most strong evidence related to therapeutic approaches, despite the difficulties that we still see in the treatment. It affects people with type 1 and type 2 diabetes, also with prediabetes and young patients. In the lifetime, prevalence is over 50%. There are not important differences in nerve pathology, but indeed there are differences in the data epidemiology when we refer to type 1 and type 2 diabetes. So the minimal criteria based on the consensus Toronto's to define and to consider diabetic neuropathy, when we say possible, is the presence of symptoms or signs. And when we say symptoms, we refer to the increased sensation, positive neuropathic sensory symptoms like sleep numbness, prickling, burning, or aching pain, especially in the toes, feet, or legs. When signs refer to the symmetric decrease of distal sensation or decrease or absent ankle reflex. The other condition would be the probably peripheral diabetic neuropathy, and we refer to presence of symptoms and signs. And in this case, we should have to find both decreased distal sensation or, again, absent ankle reflex. And finally, when we consider the confirmed diabetic neuropathy, is the presence of nerve conduction abnormality in a symptom or symptoms or a sign or signs of neuropathy. And when the nerve conduction study is normal, we have to go to a validated measure of small fiber neuropathy. Why I say this? Because unfortunately, the data that we have got in most of the studies are very heterogeneous, and then it explains how you can find sometimes prevalence data of 7% and then also prevalence data of 9%. It depends on the criteria of diagnosis that was used. So about the epidemiology of type 1 diabetes, of course, the outstanding studies refer to DCCT, EDIC, and the European Eurodiab, IDDM. The DCCT found low prevalence in individuals with newly diagnosed and early type 1 diabetes, which means a duration of less than 10 years. But the EDIC, the epidemiology of diabetes interventions and complications, found the prevalence about 34% after 12 years. So it means that as long the duration of the disease is, the higher the prevalence will be. And about the Eurodiab, which was involved in 16 countries, the prevalence was similar, was 28%, but there was no significant geographical difference. In fact, the DCCT, this publication goes back to 2014, when the DCCT EDIC completed 30 years. We can see here that indeed the conventional was much higher compared to the intensive group, and we see the same. Consider the EDIC, which was the follow-up, 41% versus 34% for clinically evident peripheral diabetic neuropathy. And also when we see here the complication of autonomic neuropathy, again in the EDIC years, we see that 135 versus 29 compared to the people who were treated under intensive approach. The neurodiabetes also showed that something very important many years ago, that even for type 1 diabetes, we have to consider hypertension, smoking, glycated hemoglobin, change in glycated hemoglobin, the diabetes duration, the BMI, and also triglycerides and total cholesterol. All these factors that are also related to the cardiovascular complications are also associated with type 1 diabetes, although we know that the glycemic control is very important. So we can say that not only glycemia, but also metabolic risk factors are involved in the pathogenesis and in the epidemiology of type 1 diabetes neuropathy. The more recent study, especially the Exchange Clinic Network, which involved over 25,000 people with type 1 diabetes in over 80 pediatric centers in the US, plus the Scottish type 1 register, which refers to real-world cohorts, the prevalence rates were about 11 to 13% for symptoms of peripheral diabetic neuropathy. And the traditional risk factors, glycemic control, age, diabetes duration, CV risk factors like obesity, hyperlipidemia, hypertension, smoking, and plus socioeconomic risk factors appear, all of them, as very strong predictors of diabetic neuropathy. I have to say that both studies from different parts of the Atlantic used the neuropathy screening instrument to phenotype diabetic neuropathy. About the diabetic neuropathy epidemiology of type 2 diabetes, we have several observational interventional studies which point out all of them to high prevalence. So we can say that over 50% of individuals present signs and symptoms of diabetic neuropathy during their lifetimes. And the rates range from 20 to 30% even in new diagnosed and early type 2 diabetes. The most recent study, or the addition, the Anglo-Danish data study of intensive treatment of diabetes in primary care involved over 500,000 individuals with screen-detected type 2 diabetes, especially in the Danish arm. And when we consider also the greatest study, the glycemic reduction approach in diabetes, which involved over 5,000 individuals with early type 2 diabetes, that means about 4 years duration, the traditional diabetic neuropathy risk factors, such as glycemic control, age, and diabetes duration, but also racial, ethnic, minority status, all of them carried a higher risk of diabetic neuropathy, including the American Indians. Again, in these studies, the Michigan questionnaire, where you applied it to phenotype diabetic neuropathy. And more recently, we can also refer, as I said in the beginning, to search. When I say this, it's a search study, and also to search clinically type 2, the diabetic neuropathy among type 2 diabetes in the young. So over 2,000 young people with type 1 and type 2 diabetes, but mainly type 2, the prevalence were similar to adults with type 2 diabetes. Another point that is very important to consider is the prevalence of diabetic painful peripheral neuropathy. It affects about 30% of all individuals with diabetic neuropathy. It is really difficult to manage, and of course, you are going to hear about this in this course. And the increased risks associated are sleep disturbance, reduced quality of life, polypharmacy, socioeconomic consequence, for example, high costs, and reduced ability to work or perform the daily activities, high mortality and morbidity. So the high prevalence and its clinical and socioeconomic consequence demand, in fact, an effective therapeutic and preventive measures. Indeed, the neuropathic chronic pain caused by diabetes follows the same patterns as the neuropathic side. I mean, from distal to proximal direction, toes, feet, and legs. And we really have to consider during the clinical history and, of course, to apply the proper physical examination of the patients. Another special conditions that are associated with diabetic peripheral neuropathy, but is still overlooked, I would say that we have to consider pre-diabetes and type 2 diabetes, especially the early cases. So in metabolic health individuals, as we can see here on the left side, the mitochondria produced in the nerve do the traffic down the axons. It means that it provides the necessary energy for the normal axonal function. But among pre-diabetes and type 2 diabetes patients, the chain of injurious events leads to this mitochondrial dysfunction and the ATP loss and the distal to approximation, the generation of energy-starved axons. So we can say that the metabolic syndrome has emerged as an important risk factor for neuropathy, and this data come especially from multiple clinical studies in the US, Denmark, Germany, Netherlands, India, and China. So it's a very important consideration to search for diabetic neuropathy in pre-diabetes and also in early type 2 diabetes. This very nice data come from the Professor Eva Feldman group, and we can see here the presence of diabetic neuropathy in pre-DM ranged from 11 to even 49% versus 30.5 to even 29% in normal glycemia. Most of these studies, including Ziegler and Callahan, Lee, Franklin et al., they used either score of symptoms plus exam or the Michigan score or the consensus Toronto. It's indeed a reality that we have to consider all the examination and the investigation among these patients. Another problem that is increasing, and it refers to the sensory motor mechanisms, are the falls. The risk of fall among people with diabetes and diabetic peripheral neuropathy. So this data about 2 years ago showed that the falls in general aging population is recognized as a clinical problem. And we can say that 1 in 3 people over 65 years will have a fall each year. Falls in people with diabetes is also a very big problem, and even I would say a greater clinical challenge. In diabetes plus neuropathy is up to 20-fold more likely to fall versus the same age-matched non-diabetic control. So studies have now established peripheral neuropathies as a strong independent predictor of falls risk, and we have to analyze this, especially on the scenario of large fiber motor fibers damage. So neuropathy promotes muscle morphological abnormalities which affect both the most distal parts of the lower limbs, but also more proximal lower limb muscles. So in a retrospective study involving over 44,000 people, again, the diabetic foot ulcer history were twice as likely to fall, the ratio of 2.26%, 22.6, compared to patients who had not suffered a diabetic foot ulcer before. So we can say that this late complications of diabetic peripheral neuropathy, which includes also the problem of ulcers, are involved in this process of mechanism increasing the risk of fall among diabetic patients with diabetes. So this is the diagram that we can consider. So the peripheral neuropathy promotes absent sensory feedback, then altered gait biomechanics, again here increases the risk of fall, but we have to consider the motor impairment comes again the decreased physical activity, because especially in security, balance impairment, and then again risk of falls. So we have to also to remember these overlooked social determinants of health in their impact on diabetic neuropathy. It's a very big scenario to discuss and to study, but all these problems, economic stability, education, healthcare access and quality, physical environment and social environment, all these are in the process of lack of food screening, the access to care, and we have to also to concentrate in self-care behavior, especially to invest in medical adherence. Plus, of course, the glycemic control, which is also disturbed. All these conditions as social determinants of health contribute to increase the peripheral diabetic neuropathy. So social deprivation, lower education status, and limited healthcare access are risk factors for diabetic peripheral neuropathy. Of course, we need future exploration of other social determinants of health and see how they contribute to increase the DPN risk and progression that we have to analyze in the future. So I thank you very much. Muchas gracias. Muito obrigada. And I hope you can find this data interesting. I'm sorry I cannot take questions because this is a recorded session, but I will be very happy to receive any emails or communication from you. Thank you very much again.